Good evening, everyone. My name is Jean-Christophe Leroy, and I'm chairman of Positive Minders. I'm very pleased to welcome you to this event organized by the European Society of Social Psychiatry and hosted by Positive Minders. While we are waiting for the latecomers, would you please indicate in the chat room the city and the country you are connecting from? So we've got people connecting from Paris. Hello, Paris. From Geneva and Montreal as well. Nyon in Switzerland. Lève in France. Oh, we've got somebody coming from Belgium as well. And Charente-Maritime in France. We are streaming this conference to Zoom as well to YouTube, Facebook, and Twitter. And we're very pleased to welcome Professor Michaëla Amering for this conference. I see that on Facebook we have people connecting from Paris and from Nice as well on YouTube. We have friends as well connecting from Alger in Algeria. I've seen that Professor Amering has got a fairly long presentation for us tonight. So maybe we could shorten a little bit the time to start. And then I propose to hand over now. I'm very pleased to hand over to Professor François Ferrero for the introduction. Professor, the floor is for you.
Thank you, Jean-Christophe. Good evening, everyone. Maybe for some of you, good afternoon. I don't think good morning. I don't know. I am François Ferrero, the current president of the European Association for Social Psychiatry, who is organizing these webinars with Positive Minders, and also a former and honorary professor of psychiatry at the University of Geneva. My main interests were for years social psychiatry at large, psychotherapy, and other domains, including, of course, human rights in psychiatry. It is a great pleasure to welcome you to this second webinar organized by the ESSP, which is a still young society because it was founded in Geneva in 2015. One of the main objectives of the ESSP, is to promote mental health through education of health workers, policymakers, decision makers, and the community at large, and also to promote national and international collaboration among professionals. So the idea to develop these webinars seems completely congruent with the aims of the society. As you all know, due to the COVID pandemic, it was impossible to organize our second European Congress. We hope the situation will improve and that we will organize it maybe in 2033, probably in Rome, but we are not sure at the moment. So this evening, I have the pleasure to introduce Professor Michaëla Amering. She will speak on Together We Are Stronger, Trialogue, Recovery, and a human rights-based approach to mental health care. Her lecture will be about 30 minutes, and I would like just to present Michaëla for those who are not familiar with her. Michaëla is a psychiatrist and a psychotherapist, professor at the Division of Social Psychiatry of the Medical University of Vienna in Austria. The main focus of her clinical, teaching, and research activities is on the situation of persons with a diagnosis of schizophrenia. She's a proponent of the concept and practice of Trialogue, a setting which allows communication and collaboration between people with a lived experience of mental health problems, their families, friends, and mental health professionals, generating a specific and independent form of acquisition and production of knowledge. Her book, Recovery in Mental Health, Reshaping Scientific and Clinical Responsibilities, published about 10 years ago, had a very strong international impact. With her co-author, Margit Schmolke, they received the Medical Journalist Association Open Book Award. Michaëla has developed numerous collaborations for promoting the recovery concept and more generally, human rights in mental health. She is a prolific author and very active in organizing international conferences. She is honorary member of many associations, including World Psychiatric Association, European Psychiatric Association, World Association of Social Psychiatry, and of course, European Society for Social Psychiatry, among others. She is the 2021 winner of the European Psychiatric Association Constance Pascal Helen Boyle Prize for outstanding achievements by women in working to improve mental health care in Europe. Thank you, Michaëla, to be with us this evening. And now the microphone and the floor is yours.
Thank you very much, dear François, dear friends, dear European Society for Social Psychiatry and Positive Minders. It's a great pleasure and an honor to be with you tonight and to share my screen and talk about this topic that I think together we are stronger. Currently, I see it's a special time at the moment. The way I see it currently is that the concept of recovery and its roots and consequences, as well as a large body of data and the current human rights situation, seem to agree on a way forward for our specialty of psychiatry with enhanced effectivity, accessibility, and reputation through cooperative efforts and coordinated actions. It was almost 20 years ago in 2002 when Margit Schmolke and I sat on a park bench in Washington Square Park after having listened to Courtney Harding's talk about recovery. At this talk, she had presented not only her amazing data on the very long-term course of schizophrenia, but she also presented photographs of people who had lived in institutions, some for many decades, and had moved back to the community. And it still gives me the goosebumps. It was a beautiful experience to listen to her and to see these people and get to know these people. And Margit and I thought we need to bring this concept to the German-speaking countries. That was our very strong feeling at that time. And these photos also then made me look for all these first-person accounts and for all these life stories that are the cornerstone of the recovery movement. Many people came out and said, we who have experienced recovery, which seems to have become alien to everybody else, we take ownership of this experience and we share it. We share it with other people with mental health problems. We share it with the workers in mental health and with society in general. Some of them were our colleagues like Dan Fisher, Kate Jamieson, Helen Glover, but many, many others around the globe started to tell their stories of recovery. Of course, we as psychiatry, we already knew from epidemiological data that for almost all mental health disorders, and not only, but exemplary also for schizophrenia, it is true that people symptomatically recover when they have a chance to have early support and treatment. We also know that there's social recovery possible even after very long-term courses of disabilities. And there's the great names of the very long-term studies, including, of course, Norman Sartorius. So that was when we decided to put this in words. And nowadays, it is the case that recovery is the guiding mental health principle in important English-speaking countries, with growing impact around the globe. And very early on already, the US stated very ambitiously that recovery is talking about a world where everyone at any stage of life has access to effective treatment and supports essentials for living, working, learning, and participating fully in the community. They also early on stated the barriers that they see: leading stigma that surrounds mental illnesses, the unfairness and discrimination in many health insurance systems, and the fragmented nature of our mental health service delivery systems that we're still combating. And these stigma and unfairness and discrimination, of course, have been a long-term been addressed to overcome. And Norman Sartorius, again, I need to name you, Norman, because you're a big part of these efforts of the last decades. And in a very important paper in World Psychiatry in 2019, you and your co-authors formulated the key lessons that you learned from the Indigo Global Network on mental health-related stigma and discrimination. And this review establishes that social contact, that means interpersonal contact between people with and without experience of mental illness, is the strongest proven active ingredient to reduce mental illness related stigma and discrimination. The review also talks about that these kinds of interventions are especially important for young people, that virtual and social media contacts might have the same effect as face-to-face contacts, and again, that there's a research gap on all of these issues in low and middle income countries. But there is a lot of research going on, and the newly established Landsat Commission on Stigma and Discrimination in Mental Health is co-chaired by Charlene Sunkel, a person who with a lived experience of living with a diagnosis of schizophrenia, and the founder and CEO of the Global Mental Health Peer Network, together with our well-known to all of us colleague, Sir Graham Thornycroft, professor at King's College in London. And they will report in 2022. So this is a co-chaired cooperative effort between people with a lived experience and people who are researchers and work in the services. This kind of lived experience leadership has, of course, been called for by the recovery movement from the beginning. It was always clear that it's key that people in recovery lead the way. Recently, a group around Larry Davidson formulated that there exists a window of opportunity that could maximize lived experience leadership, and that window may be closing fast if broad-based actions are not initiated now. One of those actions, of course, is the Landsat Commission, and there's action going on all over the place. I would be very interested to discuss whether it's enough action happening at the moment. The same is true for recovery and peer support. It was always clear that peer support is a key component of recovery, and we have arrived at the conclusion that it has great promise for the future of services to promote recovery. When we look at the research, I would like to show you this recent bit of research about the situation in France by Viviane Coves and her colleagues. And they conclude that as this new kind of care is emerging and seems promising in terms of benefits for not only the users of services, but also the peer supporters themselves and the teams of health professionals, they formulate, we also insist on the need for a systematic, scientific, and objective evaluation of the programs. And even more recent review, a meta-analysis of one-to-one peer support in mental health services states that it seems to have a positive outcome on psychosocial outcomes, and that to improve the database, there needs to be a selection of outcomes that relate to the intervention mechanisms, that there needs to be an exploration of the heterogeneity in the implementation of peer support and focused reviews on specific types of one-to-one peer support. So this research field is growing. There's currently a randomized clinical trial going on about peer support for people with severe mental illness in many different countries, and they formulated as their primary outcome social inclusion. Secondary outcomes include empowerment, hope, recovery, and health and social functioning, but they also do a cost-effectiveness analysis. In the presentation of this trial that is ongoing now, they also, the researchers also stated that this RCT will explore the essential components necessary to create a peer support model in mental health care, while providing the evidence required to sustain and to eventually scale up the intervention in different cultural, organizational, and resource settings. By actively involving and empowering service users, UpSide will move mental health system towards a recovery orientation, emphasizing user-centeredness, community participation, and the realization of mental health as a human right. Very specific formulation there. And I have said this many times before, but I would like to share with you, my friends, and all of you, that I would so very much like to be better able to understand what are different movements and trials and research about. Is it about becoming part of evidence-based medicine? Is it about a human right, health as a human right? Or is it about health economy? And I think this is especially important around this topic of peer support. What is expected from us, from the services, from the side of recovery? Recovery says services need to be person-centered, integrative, rights-based. There needs to be a collaborative commitment for change, not a paradigm of stability or nothing happening. It needs to be change for the better. It needs to be cooperation with self and peer help, advocacy of service users and family carers. The outcomes need to be about leading a meaningful life and support in social roles, as a mother, as a worker, as an employer, as a lover, versus and not about symptom and service use reduction. And this is for me very important, that recovery states that we should stop measuring the success of our interventions by service use reduction. On the other hand, we should see that the services are really happening in the context of human rights and patient rights. So when we look at all this, we think we all know that already, and we should just do it. But I've not seen so many models. I've seen one, and Lieselotte Mahler is here tonight, and I'm much looking forward to hearing from her, because what she did with her team in Berlin was really implement what we already know in the Wedinger model. And I was happy to comment it when they did it, that it's amazing that they are just doing it. It must have been very difficult. I know it was very difficult, but they succeeded. They just did it. And now they have a recovery-oriented service that strengthens the therapeutic relationships and prevents coercion. They have done it. They have researched it. They are maintaining it. And that is not happening everywhere yet, because I often feel that psychiatry in terms of recovery orientation understands that it's not implementing already what we know, that it is saying with this sentence that I like very much. In German, it's by Öden von Horvath. It says, eigentlich bin ich ganz anders, aber ich komme so selten dazu. In English, it means, really, I'm quite different. I just so rarely find the time. So we know, but we don't appear as we want to be. We are not seen as we want to be, because maybe we are not as we want to be. And I would like to mention here Vikram Patel, Professor of Global Health at Harvard Medical School, at the last World Congress in Lisbon, where he said we should not only talk about the treatment gap, we in psychiatry need to talk about prevention gap, quality gap, and the credibility gap. And he says that mental health for all will only happen by involving all. Because, again, to say what I sometimes deplore is that we sometimes appear to hurt people. And Pat Deegan, psychologist at Princeton University, I think, I don't know, psychologist, at an American university, researcher, very important person in the recovery movement, having lived with the diagnosis of schizophrenia much of her life. She talks about how too often the human services dehumanize and depersonalize those who come to receive services. People with psychiatric disabilities are frequently hurt by helping professionals. The phenomenon of spirit breaking is introduced. So she writes about suggestions for rehumanizing the human services are made, including new models for clinical interaction that serve to empower rather than disempower service recipients. And she talks about the contributions that people with disabilities are making in their own state and national movements for social justice and the right to humane treatment and rehabilitation services. And people have, she wrote that in 20 years ago, and people have done that. And one of the outcomes of the activity and contributions of people is this historic document of the UN Convention on the Rights of Persons with Disabilities. Historic in many regards. It's the first time in history that people with disabilities that come from mental health problems are part of the larger disability and very large disability community. And it's the first time that people with disabilities, their advocates, have been part of the negotiating and drafting process of this UN convention. And that's, of course, how the convention looks. The convention is trying to make a reality of nothing about us without us. It's based on a social model of disability with a focus on non-discrimination and social inclusion, and the product of a truly participatory process. Correspondingly, it asks and obligates states that no policy development, no amendment of legislation or elaboration of new regulation shall be undertaken without including experts in their own right, persons with a lived experience of mental health problems and services. That is true for everything, as I've said, but importantly also for the monitoring process for the implementation of the UN Convention. In all of our countries right now, these monitoring processes are happening and are very important. The UN CRPD had unprecedented support worldwide with 182 ratification in over 160 countries of the world. It's national law because it becomes national law by ratification. It's a very strong convention. As a historic first, also the EU has ratified as a whole, building with its then 28, now 27 countries. The legal profession has commented this, of course, prominently also. This is Peter Bartlett, saying that the CRPD developed rights to non-discrimination in key areas, including employment, housing, education, health, standards of living, and social, political, and cultural participation, along with the right to be free from exploitation, violence, and abuse. And he announces, and we see that now, that the lawyers and legal academics are refocusing on people's community rights. These community rights include, according to the UN Convention on the Rights of Persons with Disability, living independently and being included in the community, respect for home and the family, education, health, rehabilitation, work in employment, and many other areas, and of course, participation in political and public life. The good news from my point of view is that we have data that show us that we can work within these rights that people have to non-discrimination in support. Our data today show that respecting the individual needs and preferences as asked for by the convention is at least as effective as traditional interventions and institutions. We have this data, for example, regarding supported housing and supported employment. And that also means that the long-term, very long-term request of first place, then train, and not put people somewhere for a training and then let them try to succeed in the community can become a reality. And that, of course, is true for all the housing first problems, first initiatives, for the job coach projects, as you have in Switzerland, for supported education, supported parenting, and that personal assistance in the community is of great importance. So this is, again, from my point of view, old knowledge. It's also new knowledge. We have data clearly show that for centuries, for decades, and very actually now with the newest scientific methods, we know that the most effective interventions are those that support persons with mental health problems in their everyday life. And I want to give this example of the newest research that shows that new network analysis that have only been possible in the last year through how the computers have evolved. And Italy, with a large cohort of people with psychosis who live in the community, who have been, whose data have been analyzed, and clearly show that the high centrality of functional capacity and everyday life skills suggests that improving the ability to perform tasks relevant to everyday life is critical for any therapeutic intervention in schizophrenia, and that these data-driven analysis support recovery-oriented approaches with a focus on basic functioning goals more than on symptom control. So some of us have been sitting together and trying to find out what that means for innovative practices around the globe, like supported decision-making, reasonable accommodation, co-production of health, dialogical approaches, advocacy. Some of us have been bringing together all the knowledge about how can crisis response happen in the community where people are, and when they don't want or need to be hospitalized. And WHO has come out and said A human rights perspective is essential in responding to the global burden of mental disorders. And Michel Funk, the head of the WHO Quality Rights Initiatives, early on said that they find that people are ready for and want change in mental health. And it will be interesting to see how their quality rights e-training on advancing mental health, eliminating stigma and promoting inclusion works that will be launched this coming spring in the year 2022, and is designed to reach really thousands and thousands of people all around the globe. WHO has also come out this year in July with a guidance and technical package on community mental health services, where they state that in order to successfully integrate a person-centered, recovery-oriented and rights-based approach in mental health, countries must change and broaden mindsets, address stigmatizing attitudes, and eliminate coercive practices. They call this promoting person-centered and rights-based approaches, and they have given guidance to all sorts of different areas of mental health care, crisis services, community outreach, peer support. They have formulated that in that way. So that means that we are facing the idea and a lot of interventions that try to make a paradigm shift really from a charity-based to a rights-based approach. The UN CRPD also commends this paradigm shift in attitudes and approaches. It says that persons with disabilities are not viewed as objects of charity, medical treatment, and social protection, but rather as subjects with rights who are capable of claiming those rights and making decisions for their lives based on their free and informed consent, as well as being active members of society. We've, of course, known that the idea that self-determination is a health resource is also an old idea. Recovery then has brought the concept of the dignity of risk and the right to make mistakes. And of course, now we have the right to non-discrimination as formulated in the CRPD. That means people have a right for support to self-determination, for a self-determined life in a community-supported living, working, family life, but also support for their decision-making. The ideas, the supported decision-making can replace substitute decision-making. So this is a big thing. And of course, this idea has also raised a lot of worry, indignation, conflict, and I think there really is a great need for discussion. And because of many reasons, but one important reason in my view is that being there, helping out, and deciding for somebody who seems unable at the moment is a precious good in human life and society. It's precious to all of us. All of us also know about the risk of unwanted effects if we decide for somebody else. So dealing with this idea of supported decision-making, I think we need really a broad discussion in easy language. That's also a human right. By the way, I think it's a great human right, and in Trialogue. And I wanna say a few words in the last minutes about the Trialogue. The Trialogue is a form of communication between service users, family carers, and mental health workers beyond role stereotypes. In Trialogue groups, users and ex-users, family carers and friends, and mental health workers meet regularly in an open discussion forum that is located on neutral terrain outside any therapeutic, familial, or institutional context, with the aim of communicating about and discussing the experiences and consequences of mental health problems and ways to deal with them on equal footing, as experts by experience and experts by training, or both on eye level. You see Dorothea Buck here, and she's the inventor of the Trialogue. And never letting again break down this dialogue had been an essential goal of hers when she introduced this Trialogue idea. The experience of the worst forms of human rights violations, including forced sterilization and the murder of people with disability, especially also people with mental health problems at the time of the Nazi regime in Germany that she lived through, had motivated her as a survivor of that time. So her idea is that as long as we speak to each other in this kind of respectful communication, we are not a danger to each other. And I always said, I'm not completely sure that she's right, but I think it's so worth trying. And in our experience and in our research into Trialogue, we could see that really the communication in Trialogue groups is very different from a communication in clinical encounters where the same people meet. All three groups in a Trialogue cherish and aspire to interest for each other, goodwill, and openness. And that the daily clinical routine that we work in with role prescriptions, power balance, and constant pressure to act is experienced as an obstacle. So we concluded, as François said, Trialogue does facilitate a discrete and independent form of communication and acquisition and production of knowledge. The first Trialogues happened in Hamburg, where Dorothea Buck lives. There's well over 150 groups in Germany today. There's at any given moment, there's many thousands of people involved in Trialogues. There's Trialogues in Switzerland, in Austria, in Switzerland, in France, Liechtenstein, Poland, many other countries. And there's growing interest in the English-speaking countries. The first Vienna Trialogue we had in 1994. As a consequence of the World Congress of Social Psychiatry in Hamburg, where we experienced that. It happens every second and fourth Monday of the month. It includes 10 to 60 people. It takes about 2 hours. It happens on neutral ground in an adult education facility, and the role of moderator rotates within the group. I've had the pleasure to be part of the first Trialogic working group at the World Psychiatric Association level. I was so pleased to have been part of a Trialogue in Beijing. You can see Richard Warren there also, and many of our many colleagues from around the globe, but also from China, and it was so impressive. It was such similar worries, statements, topics, tears, fun, laughter. It was great. I had the pleasure also to be part of a year of an implementation project over many years in Ireland, where we also did interesting research into how a Trialogue can be implemented and what it can do for a community. In conclusion, it's clear that to me, that together we are stronger, that the Trialogue experience is indicative of our capacity for surviving and gaining from serious arguments about adverse issues, as well as the great possibilities of cooperative efforts and coordinated action. And I'd like to thank again François to mention this wonderful prize that I got from the European Psychiatric Association. And I'm especially happy that in the argument, it says she is a proponent of the concept and practice of Trialogue. So that was great for me. And two last thoughts that I want to share that have to do, I think, with me being a woman. I find it a great challenge to understand this human rights perspective. I think sympathy for a human rights perspective we all share, I think, but understanding what it means, I find it quite challenging. And one of my friends, Marianne Schulze, who's a human rights lawyer, she helped me by saying, to appreciate the significance and the potential of the Convention of the Rights of Persons with Disability, you need only to think of the human rights challenges of another group, in fact, the world's majority. Legal capacity and non-discrimination, but importantly, the right to act in the legal capacity for women was formulated by the Convention on the Elimination of All Forms of Discrimination Against Women by the UN in 1979. It had enormous consequences around the world, and we hope that its effects are irreversible, but we also understand that there is still much to do after 40 years after this convention. So currently is the Convention on the Rights of Persons with Disability, which is causing significant societal processes, which require us to question old mantras on the one hand, and radical new thinking as well as acting on the other hand, also in our field of psychosocial issues. And I can't resist stopping with this slide where Albert Einstein says, insanity is doing the same thing over and over again, expecting different results. Thank you very much for your attention.
Thank you so much for your wonderful presentation, going through human rights at large, recovery, the UN Convention, Trialogue. It opens so many doors. We will visit some of them during the discussion. And without delay, I would like to present briefly Professor Yasser Khazaal in a few words. Yasser is a psychiatrist and psychotherapist trained in France at René Descartes University in Paris and in Switzerland, including partly with me. He soon became interested in all forms of addiction, an area in which he became a renowned specialist. Thanks to his research, often of great originality, and of his numerous teaching activities, he was first appointed associate professor at the University of Geneva, and he is now full professor of psychiatry in Lausanne and co-director of the addiction department. Yasser has developed numerous international collaborations, and he is already an author of more than 200 publications. When I chose to end my role as president of the Swiss Society of Social Psychiatry many years ago, it was obvious to me that Yasser would be a very talented successor. But I discovered that he was much more than that. Together, we have developed a strong collaboration, a strong friendship, and with some other colleagues and good friends, we have created the ESSP. Now, Yasser, the word is yours. Please give us your comments.
Many thanks, Francois, for your kind words. And I would like to thank you for this session and to thank Positive Minders to work together with us in this session. And thank you very much, Michaela, to Professor Michaëla Amering for this very nice conference on this very important topic for us. When hearing you, Michaela, I have in mind the last sentence we said about Einstein not doing the same thing and expecting different results. And I remember that to some extent, maybe the CRPD process was give something new, maybe because, like you said, the association of people with disabilities were already associated in the process, and probably this point led to a different outcome. And the main outcome for me is related to the importance of social inclusion in the basis of equality. And so when I look today to the main outcome of assessment of mental health services, I see that the main outcomes were more related to service use, to psychiatric symptoms, to financial issues and service costs, and to some extent, a little bit to user satisfaction. And so there is no outcome related to social inclusion, no outcome related to housing, to supporting other aspects of life. And we know that most of the patients with facing disabilities related to the barriers they faced in interaction with their difficulties. Most of them may be improved in some aspect related to psychiatric symptoms, but to lower level related to social inclusion and quality of life and other things. So my main question is the following, Guan, Michaela, how to now involve user association, relative association in the assessment of mental health services. It is one of the needs and the request of the UN Convention, and how to do it effectively to really change the way we are working and assessing what we are doing. Thank you, Michaela.
Thank you very much, Yasser. Thank you for that question. And I've heard, of course, this question often. I'm thinking about it. And not long ago, I was thinking, it's really, maybe I do believe in laws now more than I have in the past, because doctors, my doctor colleagues, we are very law-abiding people, you know. The doctors don't go against the laws. So if you have a law, and the researchers, I assume as well, so if you have a law that says you have to involve the people with a lived experience in what you do, otherwise you get no funding, or otherwise you can't develop the way you want, I think we will do it. And why I think it's important to go the simple way is, it reminds me a bit of the discussion about vaccination, where now in our countries, in Austria and Germany, they say we need to oblige people to get vaccinated, because they just don't do it in any other way, and they don't lose face if they just go with the law. So, but why I'm hopeful about this way is that I have seen all over the world, really, the people with the lived experience, the families, and especially also the people with self-experience, they are so fit, so wise, so ready, so generous with sharing with us these kind of responsibilities, like creating better outcome measures or creating better services, reducing the risks. They are there now. So I think we should, even if some of us are hesitant or feel they don't have the time or whatever, I think we should just have to do that and all get into this, be able to benefit from sharing our responsibility, if that's okay as an answer.
Thank you very much, Michaela.
Thank you, Yasser. Thank you, Michaela, for the question, for the comments. Now it's my pleasure to introduce Lieselotte Mahler. Lieselotte is a psychiatrist and psychotherapist, trained at the Charité University in Berlin, and she's currently chair of the Psychiatry and Psychotherapy Department at Theodor Wenzel Clinics in Berlin. Her main interests are social psychiatry at large, with a special focus on sexual orientation and identity, LGBTI, and mental health. She has developed research on ethical guidelines on a case-based approach. She's currently developing the German practice guidelines on prevention of violence and coercion in psychiatry. She wrote numerous publications, is extremely active in teaching, and is very much involved in social psychiatry, fighting for human rights in psychiatry. It's a pleasure to have you here with us, Lieselotte. I give you the floor.
Thank you, François. And thank you, all of you, that it was possible to make this web seminar. Thank you especially, Michaela, for your thoughts and your work during the last decades to make this possible, to connect things like recovery, what is, for me, the change in paradigm we need in psychiatry is to see it the other way around, and connecting to what Yasser was saying is the outcome focus, or what is needed for psychiatric treatment. And as we said before, like guidelines, evidence-based medicine, you know, the promising of psychopharmaca, the promising of neurobiological measures, fMRI studies. There was a dedicated to say this is a solution, and we just see no, it's not. Because sometimes in our discussions we have the feeling that it's like we say in German, old wine in new bottles. But why is it so? Because all those promises that were made from science didn't come true. And so for me, the recovery movement and really Michaela and Margaret Schmolke's book was so important to bring the connections between people who have own experience in the focus of the treatment. And this connection is, I think, what should have been done long time before. It is the power of interpretation, what Michaela was saying, the power of interpretation, what helps, what should be focused on, what is the outcome, what is efficacy of the therapy. So all the datas are really, as you would say, like really clear. It's not what we were saying it is. It's different things. That was Yasser also was saying. And I found this wonderful word from Fred Fries in your book, Michaela. He's a science, and he was recovered from schizophrenia, and he said what is needed is evidence-based interventions as well as individual unusual solutions. This is a very simply sentence, but it has all in it. So the thing is working more with peers and teams, bringing the experience of the people. And so what I think need is that a user-driven psychiatry. User-driven, what means we are not giving like a treatment, we are more like in support and understanding what is the problem. And then we have a huge efficiency in our treatment. So Michaela, my question to you would be, is it needed like not to try to bring what recovery and the human rights driven solutions to bring it in our structures how we have it right now, or should we just close everything and rebuild a totally new system? Or do you think it's possible to bring what we know, what is helping in the structures we have right now, like a vision? What would you say?
Yeah, I mean, I know your model and that you have done it. And when I'm asked what is the success, what is the secret of success to do that, I say, and I would like to ask you that question, I say if the nursing profession, the doctors and the leadership together want this top down, then it works. It doesn't work any other way. It's of course important that people have the right spirit, the right mindset, and the people who work there want to do that. But it really needs a strong, and it needs the different helping professions to work together. I think we have to deal with what we have now, because I think the medical profession has a lot of power. And also psychiatry has much too little resources around the globe. I understand that, but the medical system is still the safest system in terms of resources. So I think we should keep these changes and transformations within medicine. We should not lose the power of the medical profession and the medical system in order to support people, as you called it. So it would be great if we could change in the right way within the system, and maybe the system will then adapt to us. That would be the hope.
Thank you, Michaela. That's a discussion we just had, and I think this is such an important point you are making. And thank you for your answer.
Yeah. Thank you to you, Lieselotte. Thank you to Michaela again. And it is my great pleasure to introduce Andrea Erisman. She's a peer support specialist since many years. She has developed collaboration with several associations throughout the Swiss French-speaking part of Switzerland, and also with the University Psychiatric Department in Geneva. And I understood that it is not an easy task. She's very active in this French-speaking part of Switzerland, and among other activities, she's currently co-president of the association Repère, which promotes professional peer support. It is a great privilege to welcome you, Andrea, and I give you the microphone now.
Thank you very much for having me. And thank you so much for this presentation, which actually, Michaela, which really gives great credence to our cause of peer support workers. It's actually like the best publicity that we could have, really, to hear all this. It makes me very well, comfort. It's great comfort to me to hear that, because indeed in the current situation in the Swiss German part, this is not we have to kind of fight for our profession. I mean, we have to. It's not easy to get professional, how do you say, positions, which is actually also by our association Repère is quite active here, and we try to promote this new field, which is only really active in the Swiss French part since 2014. So that's when I started working as a peer support specialist. And it's really, there seem to be not enough resources for these jobs. It's hard to sometimes, I mean, it's just not an open-mindedness to this new role yet, I guess. So we are pioneers in that respect, I think, and I think that now I can say that when I first heard about this new role, I thought I would like to do that, because it would have been greatly helpful to me at the time, because I think I had such, certain very wrong ideas about things. And if I could have spoken to a peer support specialist, I think it would have been extremely helpful. And this is just a little bit of, how do you say, a funny way of saying it, but I have this concept, which I call the magic wand concept, which is what really a lot of the people who are having mental health issues have. They would just like this to go away. They would just, like this. This is all unfair, and which is true. It is unfair to live with these difficult conditions, and so a lot of this is, it's like I would try different things, and I think a lot of people can relate to that, and things just don't work very quickly. The magic wand isn't a good magic wand, by the way, is a baguette magique for the French speakers. And I just feel like that's something that we have to have also very, how do you say, very effective and concrete tools to work with for people concerned, people with mental health issues, that we have self-management, how do you call it, autogestion, self-management tools where we can learn how to plan our recovery. And these, I think these tools should be really also available and be promoted in the network, so that that we can, how can you say, accompany the people to take the little steps, because sometimes it is indeed the very little steps. And I think with having peer support workers, maybe you know, have this accompaniment is I think it's important, because I think it's also the how do you say, the témoignage, that we can get better, that we can overcome difficulties, that we can learn new competencies, that we can maybe become more positive, that we can become we can maybe have a routine more easily, and so I think there have to be concrete things that we do, and that we have available for the people concerned with mental health issues, because it's just, I think, always coming then back to the auto-stigma situation, which keeps the person kind of stuck in their situation. Because, and I really think that was so nice to hear that what you said about that it's like the most important thing is to be part of the society, to feel that we belong, that we have a role in society. And I think that's really something that's that I think has to be worked on very, I think, very much. And also, I mean, I'm maybe trying to say different things now, just because I have the chance also to do that. And I think also it's important that we have opportunities to learn, like some of the recovery colleges, or that we have the, that's another also concrete thing, is that we have the plan, plan conjoint de crise, which is a joint, I wrote it down actually, sorry about it. It would be the plan, joint crisis plan, which is something that's a concrete thing that we can have to improve our health, and maybe stay away as much as possible from hospital stays, and that these stays can be as best as possible. And yeah, so I think that peer support is really a long-term wish, or a long-term project, that it's quite, at the moment, not at all. Well, I only have one day at the university hospital in Geneva, one day for, I think it's 1,000 employees in the psychiatry psychiatry part of this hospital. And so I think, I mean, that's always, it comes, and it's, I think, also very interesting what you said with, it has to be a top-down approach, which is, I think, not the case. And which then I salute the people who are on the field, because they are all quite, how do you say, quite, they agree it's necessary to have peer support. And so, yeah, hopefully at some point they will find that we can have enough budget and enough means to get more peer support workers. Yeah. So I hope it's okay for everybody that he took this occasion to plead this case. Thank you.
Thank you very much, Andrea. It was very important to hear you. It's very personal and sensitive and very helpful to all of us. Now, it's my pleasure to present Norman Sartorius, but how to present him? We developed our collaboration since his time at WHO, that is to say more than 30 years ago. I had the pleasure to present Norman on many occasions. Nevertheless, it is always difficult to me because he is so creative and so active that it is quite impossible to select only few of his achievements. He is currently the president of the Association for the Improvement of Mental Health Programs, and he used to be president of WPA, of EPA, director of WHO Mental Health Division. Then he became professor of psychiatry at Geneva University and at various other universities, including in the USA, Czech Republic, England, Croatia, and other countries. He received countless prizes and honorary titles that I renounce to list. He has written more than 500 articles in peer-reviewed journals, chapters in books, and wrote, edited, co-edited, or co-authored about 120 books, probably more than that today. It was the number yesterday. Despite his many activities everywhere around the world, one of his main interests is to promote better mental health programs and to fight for human rights in psychiatry at large, and especially for destigmatization. He published an essential book on this subject, as you all know. We are very happy to welcome you, Norman, and I would like to take this opportunity to thank you for your so important and continuous support. I give you the microphone, and after you, we will open the general discussion. Thank you very much. Le son, Norman.
Thank you very much for inviting me to this meeting, and thank you for your very generous introduction. I would like to start by saying how much I admire Michaëla Amering's work and her apostolic style of introducing the notion of trialogue and the necessity to listen to both people with lived experience and families and thinking about what psychiatry is all about. And it has been a long-term admiration, and I think it will continue as time goes by. But as I listen to her and as I listen about the trialogue, I find that she managed to achieve that the three voices come together. The people who had the lived experience, the families or carers, and the health workers. But I think the next challenge, which is tremendously important, is to have somebody who listens. Because it's the listener which also is very important. Yes, the three groups listen to one another, but it will be important that government and various other decision makers have a regular chance to listen to the joint voice of the trialogue. And I think that is the challenge which undoubtedly stands achieved in some countries, but sometimes not. And so I think that that's something that we have to think about. My second point is about a problem which I think is not recognized very much. And that is people consider carers to be almighty. Everything can be done by the carers. There is only one paper that I found in which was written by a newsletter of people with lived experience in Holland, in which the writer says, nobody ever asks for a set of criteria for the capacity of a family to receive back a person who has been mentally ill. What if they have three other patients in their home? Maybe a demented father and a small child, or maybe some other problems, financial or other. Never thought about this. So that the notion that we have to think about carers in a different way. Henry Brodati, in various works, he was in his time the head of Alzheimer International. He has in particular collected various ways of what we have to do to make the carers carry the burden, because it's a huge amount of work that they have to do. And not only is it 10 people every time, it's maybe just one carer who himself or herself may be sick as well and may have to take on an additional. So what can we do for them? What kind of money can we give them? What kind of training can we give them? It's a very few countries in which there is a regular training for carers, in which there is a facility which can help carers when they need it. Sometimes you think about a simple solution like the holiday for the carers, and you accept a person in a home for a week, because it's a difficult thing to care 24 hours a day for a person who's not well. So for 1 week, they take breath and they stay healthy themselves. Carers have approximately 60 to 80% more physical morbidity than other people because of the extra stresses under which they live. So I think that that's notion that the carer is the vulnerable people as well, who need to be just given help, advice, assistance in order to be a partner in all of this. And I think that's something that is sometimes forgotten. Now, of course, the notion of peers is wonderful because it brings people on who have a little bit of extra time to give. But many of the carers don't have the choice. They don't have a choice to have the extra time. They just have to do it. And I think that the peers will be greatly helping this particular development. And we've seen it in many countries that, in fact, the peer support has been a wonderful help. For me, the most beautiful example of peer support that is from a different area is the peer support in Guatemala, where a woman who is expecting a baby is given one woman from another village to come and spend 3 days with her, the last 3 days. And they talk to one another, and they embrace one another, and they eat together, and they talk about worries, and this, that, and the other. The result, the average duration of childbirth is halved 50% of the time. So it's the mental support and warmth that she received reduced the physiological process in a significant manner. And I think that when you speak to these women, they really are a different person after this experience, not only because they have a child, but also because they have the chance to make really an intensive relationship with a peer who has been experienced. Now, my third point that I would like to make is about the CRPD, the convention. It is wonderful. It has many things that are important. It protects human rights. But it is one item that is missing in that convention, and that is very important. It's the item that governments must pay money for care. They must pay money for services. I remember one particular picture that was given of a mental hospital in the Czech Republic, where a person was in a cage bed, and he was there overnight. And they published it, and it was terrible to see this person in a cage bed. But when you listen to the people, you discover that this was a ward of 100 people with one female nurse alone, with some excited person. She should have been given another colleague. They should have given more money, more attention. So I think that the CRPD is excellent. And now the next stage should be, now give us the resources to be able to implement it in full. Resources human, resources in advice, resources in everything. We should think that in mental health, we are not talking about equality ever. We are talking about equity. People who need more must be given more, not the same amount. Thank you very much for your listening.
Thank you so much, Norman. It's of course, it's wonderful, all of you, to speak with you, because then with your discussion, everything will be mentioned that needs mentioning and that I failed to mention. I want to say that when I first talked in Switzerland about the UN CRPD, I said, you know, our countries are now, they have signed, ratified, and now they see what they're in over their head, because this can cost a lot of money. The Swiss said, you see, that's why we have not ratified, because we usually calculate before we sign. But they have signed since, and I hope they have calculated, but maybe not quite right. So the monitoring process that's going on at the moment in every country, and that's an obligation by the UN CRPD, the monitoring bodies are politically super important, and they are the ones who can make the pressure. And the governments are trying to fill out of their obligations, and the monitoring process is addressing them. And I think that, so in the monitoring process, the people with the lived experience are included, but which is great. But I think if the families are not included and address the government together with us, the workers, with the users, then we will not be listened well. I think the politicians tend to listen to the families because there are many and large, but then they say, okay, we ask the experts if what you need is right. So, and the experts say, okay, we are responsible for the user. So anyway, so I think if we speak together in a politically meaningful way, that is the monitoring process, we could have a chance. And I'm also so happy that because I think the families greatly benefit from Trialogue. It's not just that they contribute, they benefit very much also. And the families are a great example of peer support, because for decades, they have, because we have let them down much of the time, they have relied on supporting each other and mutual support, and have been extremely successful, and also have fought the political fight for us, actually, because they were hoping that we would improve in a way that would also benefit them. And often we have, but not always. And yeah, these governments, they don't listen to the apostles. To whom do they listen? Yeah, the most important question. And if I may make one last remark, this example of Guatemala is so beautiful in every respect, also because of the evidence base it shows. And again, of course, there's the question, how come that something like that is not implemented in all the places that need it? I mean, I don't know. So your question, who listens, is very much, we need an answer for that, because it makes so much sense. Mm. But of course, rationality is not always the political strategy of the moment.
Priority.
And priority.
Yeah. Thank you, Norman. Thank you, Michaela. I guess it's now time to have the question and answer session. I would like to ask Jean-Christophe or Flavie. I don't know who will care for the questions. Jean-Christophe?
I will take care of it.
Okay, thank you.
So we've got a couple of questions first about accountability, because obviously you're mentioning that there is a need for inclusion, for involvement of patients or peer support. There is a need for inclusions of families, but when things are not happening, is there a need for legal change for taking better account of misdiagnostic or wrong medication or consequences of errors?
Do I think so? Mm-hmm. Yeah, I would like to repeat that I've come to believe in laws and the legal system very much through this contact with the human rights issue, but I understand that it's super difficult for any individual, to respond to the system on a legal basis. So it can be it's very hard advice for any individual person. So I think that that these organizations where we work together, or where some of the groups work together, that on an institutional level, this should happen on an institutional level, and not be on the shoulders of individual people.
Okay. Another question about, in fact, something fairly close to what the question of Yasser was. In fact, to get from talks to effective collaboration and real partnerships between all the parties, not only for evaluation of practices at hospitals, but also for research, for outpatient care, for place of accommodation, for adoption of new practice, destigmatization and whatsoever. How do you think that move can happen? Widely.
I think we need to ask Norman for that answer.
Can we ask Yasser to repeat the question?
Yeah, sure.
Yeah, please do.
How do you make the process happen that effective collaboration between all the partners is happening, not only in the evaluation of practices at hospitals, but also for research, for outpatient care, for places of accommodation, or new practices, or destigmatization? How do we all collaborate?
Well, I can only speak from personal experience. I think that it's most of the rules that will govern this are useless. And it's 90% of the things happen by personal contact. You find somebody, somebody else finds somebody else, some groups get together. And it's, I think, basing this on human relations directly. There needs to be a legal and other protection of what we are doing. But in fact, effective collaboration will happen if you find somebody who is in the right position and you convince him. A strategy which we have also used quite often is one of enlightened opportunism. That is, when an opportunity arises to do something, you jump at it. You forget your long-term plans. They are fine. Let's just put them in a paper. But we use the opportunity to create a relationship, to create a friendship, to create a thing or do something together. And I think working together gradually builds sufficient friendship to implement things. You have people to whom you can go and talk to. It's not by laws that we shall create society. It's being created by people talking to one another. And I think that thinking about who can help me is terribly important. And then go to that and develop a relationship and building it. And once you have that, then it will also be possible to consult them when you write rules for them, and you can get the rules as a product of joint agreement. I'm sure that Dr. Mahler, in writing about coercion, had to be in personal contact with many people, because that's the way to obtain information. That's the way to understand what people really want and what they will accept. And the same is true for inviting them to work with you. I think that it all has to be based on personal contacts and supported and protected by the legal system, which always is late. It always comes later. It's you work for 5 years and then they suddenly discover that they will do. If you just do a law, it's very likely that it will be very difficult to implement it. But if you have sufficient movement in the group and then produce a rule, I think the rule will be followed.
But maybe, Norman, you said before that one thing is missing in the CRPD is that the states have to pay and everything is costly. And if you want to change the system, you have to think about the way you want to pay for it.
Yes, that is true. But when I want to correct myself, when I say that we need money, I didn't think that the money necessarily has to go to the mental health service. Maybe it has to go to patients. Maybe it has to go to people who are their family. Maybe it has to go to peers. But we have to have resources with which we can operate. And I think that that's creating resources is part also of reducing stigma, which is sitting on mental health like that, and which has to be really changed if we want to change, because we ourselves must be quite sure that we are not equally stigmatizing or believing into things. But I think that it is necessary for the implementation of this program to have a goodwill and money, and that will be obtained, I think, very often with what usually is done by political processes to arrive. And Switzerland, more than any country in the world, thinks about initiatives and various other ways in which the democracy can lead to the conclusions and decisions which are useful for the population.
Thank you very much, Norman. Another question. From your experience, Michaela, what is the effective result of Trialogue, the Trialogue session you've participated to?
Yeah, it's different for different groups. We see that for people with a lived experience, to listen to others who talk about their lived experience, and then also finally arriving on finding words to describe their own experience and what they conclude from it is very important. They also have a great generosity in trying to educate other, like the family carers and the professionals from their point of view. For the families, it's wonderful to ask somebody with a similar experience as their family member, but is not related to them, and say, what you say reminds me of what I experienced with my son. What in that situation would you want me to do? Or what would you advise me to do? So they are very much learning. And I think what happens also is that the mothers and other family members, they somehow, maybe this is a too long answer now, but they have a good influence on the communication style as a whole, on the psychiatrists, on the angry young men from the user movements, on everybody. And the professionals, of course, are very interested because they hear things that they usually don't know about. They also sometimes feel a bit miffed. They say, why don't we hear about all these things that you guys do outside our therapy, our hospital? Why do we have to come here to learn about that? But at the same time, they also learn about why they don't, in a clinical encounter, don't hear about these important things. So they also learn. And together, you have such experience in a room. If you have, like, I don't know, 7 family members, 6 people with a lived experience, and 5 nurses and psychiatrists or physiotherapists, you have an answer for every question, you know? You can ask this trialogic group everything. You will always get a good answer. So you always learn, and you go stronger than you went there. That is what we really, on a very regular basis, happen. That's what happens. And of course, as Norman said, people get to know each other, and they know, because of course the families always know where are the psychiatrists who also talk to the family and not send them away. And the users know where are the new initiatives for this and that. It's just so much expertise in one room, you know. So, stop now.
Norman, you wanted to.
I wanted to just say one word. I think that another aspect of it is that families, as well as the people who have lived experience and doctors, all get changed in the course of the trialogue. They all become different in time. They learn. And then they transmit that learning to others who don't have a person who is mentally ill in their family, but they transmit that. So in a way, it's also educating the community and the society aspect, which is important.
Thank you very much. I just say two words because we are at the end of the time, or have we 2 more minutes, Jean-Christophe?
There is 2 more minutes, and obviously you've got to close.
Excellent. So just to say something about money, I guess the history of psychiatry shows that who has the money, who has the power to give the money, is in a very powerful position. The sectorization in France was not very successful because the budget was always in the hospital and not for community psychiatry and so on. We could discuss that. But it is not only a question of money, it is of course also and mainly a question of state of mind maybe, and of attitude, willingness, politic, and all of us, we have to be very active, as we understand. You are very active for promoting something different, a new psychiatry. So that's my conviction. I hope you share it, I'm sure. So it's time to close, unfortunately. It was so rich, so vivid, so enthusiastic. Thank you first to you, Michaela, for this beautiful presentation. Oh, microphone to the panelists. Great, really excellent. To Jean-Christophe, to Flavie, to the Positive Minders, and for all people who were joining us, don't hesitate to ask for a certificate of attendance. It is already ready, thanks to Jean-Christophe, and I hope with this successful and beautiful evening, we will be able to organize many other webinars through the ESSP and with the help of Positive Minders. Thank you to all of you. Bye-bye. See you soon.
Thank you. Merci.
Thank you.
Bye.
Bye-bye.
Thank you.
Thank you, Jean-Christophe. Bye.